Concord Hospital Trust What's Up Doc for June 2020. My name is Tia Teriak, and I'm a Trust Associate, and I'm very pleased to have the opportunity to introduce our speakers for today. And we want to welcome everyone who has been secluded because of the COVID issue and watching things virtually. We look forward to bringing What's Up Doc back in person in July. So information about all of that will be sent out to our audience. We've missed you very much. We hope everyone is well, safe, and healthy. Today we have Dr. Lisa Patterson. Dr. Patterson attended medical school at the Indiana University Medical Center, completing residencies at Case Western Reserve University and the State University of New York at Brooklyn. She also did a fellowship at the Jackson Memorial Hospital at Miami University. Dr. Patterson has extensive research and teaching experience, and in 2015, Dr. Patterson joined Concord Surgical Associates, coming to us from Bay State Center in Springfield, Massachusetts, where she served as Trauma Medical Director and Program Director for Surgical Critical Care and Acute Care Surgery Fellowships. Dr. Patterson is a general surgeon, and she serves as the Trauma Center Medical Director. Joining Dr. Patterson today is Katie Hartford, registered nurse and the manager for our trauma program. Katie joined Concord Hospital in 2001. She graduated nursing school from New Hampshire Technical Institute in 2004, and she worked in the ICU here at Concord Hospital until 2016. In 2016, Katie started working as the trauma program manager. In 2019, Katie successfully led the trauma program to achieving verification as an ACS verified level 2 trauma center, a distinction we are extremely proud of. Katie is also certified in both trauma nursing and critical care nursing. And in 2021, Katie will graduate from Franklin Pierce University with her master's degree in nursing leadership. We are extremely pleased and proud to have both Dr. Patterson and Katie Hartford with us for today's What's Up Doc presentation. They are going to tell us what's up with the trauma program and the trauma center here at Concord Hospital.
Thank you very much for that introduction. As she said, I'm Dr. Patterson, and we've been up with this audience before with Stop the Bleed, which had a lot of people in the room participating, so this is new territory for all of us. We do all follow the pandemic rules of distancing and mask, but for this presentation we're going without. So thank you again for the invitation. What's up with the trauma program? Well, as was mentioned, in April of last year, we were verified by the American College of Surgeons as a level 2 trauma center. Concord has been a trauma center for quite a while, designated by the state, but this is an added credential that we are recognized at a national level. We're one of several trauma centers. We'll go into that a little bit more in detail. I'm also, besides being the trauma medical director here, I work for the American College of Surgeons, and I actually go out and review trauma centers across the country, not in our own backyard, but elsewhere in the country. So this is a very good feather in our hat to be able to say that we're an ACS verified trauma center. So I took over as a trauma medical director from Dr. Rick Murphy. He was doing it for a very long time, and he's now retired and somewhere in the middle of the ocean, sailing. And that's about it for changes. Just kidding. So for those who may not, I know that some of these slides may be a little bit busy to read, but this is a very prestigious recognition that confirms that the hospital is prepared at all times to take care of critically injured patients. We work at the state level, all the people in trauma, in terms of improving trauma care around the state. So we are one of 3 centers that are now level 2 ACS verified. And there is only one level 1, which is the highest level, and that's Dartmouth, and will always only be Dartmouth. And I'll go into that a little bit later as well. This hospital has increased the staffing to ensure that we have a trauma surgeon available within 15 minutes at all times. We've also got full participation and availability of our anesthesia colleagues, MRI capability 24/7, and interventional radiology as well 24/7. So with these improvements, as well as improvements in acute care, we have been seeing an increase in the number of trauma patients being transferred into our facility, which is a good thing. Concord Hospital's trauma program has roughly about 1,000 admissions per year, which is not a high volume, but it's an important thing for healthcare in this region. I would ask for audience questions, but since we only have one person in the audience, so feel free to ask questions, Stacy. This is a map of New Hampshire, and the blue dot, as you can see, is Dartmouth. They are and will be the only level 1 trauma center. And the reason being that most level 1 trauma centers in the country are affiliated with the university. So you get a wide variety of very specialized people that focus their care in a level 1 trauma center. They're not the only level 1 in the area, but they happen to be the only one in the state. There are several level 1 trauma centers in the Boston region, which is not that far away. In terms of level 2, as I said, we attained a level 2 ACS status, as well as Elliott and Portsmouth Hospital. This is not something that you just get and you hang on your wall and you're done. This is an ongoing process that you have to meet the criteria, and the American College of Surgeons comes around every 3 years and takes a look and makes sure that you're doing things appropriately, and you get re-verified if you are. There are also level 3 trauma centers. These are places that can't necessarily afford 24/7 coverage, especially for some subspecialties. They also may have everything but a neurosurgeon, so they can take care of orthopedic injuries, but they can't take care of a traumatic brain injury, so that may be something that needs to get transferred to the next level up. And we have one level 4 trauma center. So you can see color-wise that the level 2s are orangish red in color. The level 3s are yellow. And if you notice by the map, most of the colors are in the southern part of the state. The ones that don't have any color are those hospitals that don't have a designation as a trauma center. So it may look a little lopsided, but this is actually how every state has to look at their trauma programs. It's not just the geography, it's the population. So the vast majority of the population in New Hampshire lives in the southern regions of the state. The northern regions are far less populated, and some of that is seasonal, so there's not a trauma center up in that area. We would like to get a level 3 or 4, and then most of what they see in terms of major trauma is going to transfer elsewhere. And I think the question.
Yes,
sure.
I do have a question. So I'm looking to the North Country, and are there any level 2 trauma centers in Vermont, like St. Johnsbury, where they could actually go up instead of down?
Good question. That was why I added this at the bottom. The question, I don't know if that can be heard on that.
You want to repeat it?
The question was, are there any other trauma centers in other states that may, instead of a long distance down to us necessarily, can they go elsewhere? And that is actually true. That's why I put here, trauma knows no state boundaries, so that anything in the lower region of the state in New Hampshire, a significant portion of that will likely go down to Massachusetts. With 5 trauma centers in Boston, 1 in UMass, Bay State, they can accommodate that if the patient needs to be transferred. That's what Dartmouth, sitting on the border like that, is they get a significant amount of Vermont trauma, because Vermont, their level 1 is in Burlington, which is at the northern end. So lower Vermont really doesn't have much coverage. So that's why the lower Vermont trauma will sometimes come over to New Hampshire, will also go down into Massachusetts, and the other place is Albany, New York as a trauma center. So there are no state boundaries in terms of trauma. A lot of it has to do with geography. There may be river, mountain to cross that makes it an issue. There is definitely weather that's involved, that based on whether the patient needs to go quickly, whether they can go by air or whether they need to go by ground because of weather conditions. And the other major one, which is a factor in terms of the southern areas in Boston, is traffic. Maybe the highways are so backed up that an ambulance can't get through. So those are the type of things EMS makes the decision as to which hospital is the best hospital, depending on how the patient looks, how critical they look. Other factors like age, because a pediatric critically injured child needs to go to a place that can accommodate them. So that may mean air traffic and flying them a much longer distance. So that's a good question.
So in Vermont, I believe the only designated trauma center is in Burlington.
Right. That's a level 1 and it's the only trauma center. So lower Vermont is significantly lacking, and the other area significantly lacking in terms of us is, as we said, the northern regions of New Hampshire are a lot less populated, but the southwestern is not as, it's not as densely populated as further east, but it's not like the north. So we feel that we need a trauma center in the lower part. Cheshire used to be, but they've let that go. They used to be a state designated, but because of Keene and a significant population over there, it really would be nice, because anything that's seriously injured there may go to Cheshire initially and it gets transferred to Dartmouth. The other thing is they will go elsewhere to other states. Can't really go to Vermont because that's even further, but they may actually go to New York, and Bay State gets a significant amount of lower Vermont and New Hampshire as well, in Massachusetts. So again, in terms of trauma care, state boundaries don't play a role. There may be politics about hospitals and competition and all that, but the bottom line is you want the patient to get to the appropriate level trauma center in the fastest amount of time and the safest route. Some may ask, well, why don't you just send everything to the level 1? It sounds nice, but the fact is the level 1 trauma center can't handle everything. They're like us and other hospitals, bed census may be an issue, ICU beds may be an issue, so not every injured patient in New Hampshire can go to Dartmouth. They just couldn't accommodate that. So that's why we have made it an effort and gotten these other hospitals, including ourselves, up to the level 2, so that we are able to take care of patients appropriately. And some ask, well, what's the difference between a level 1 and a level 2? I already mentioned a level 1 hospital is usually affiliated with the university, but in terms of clinical care, the level 1 and level 2, and this is with my ACS reviewer hat on, the clinical care should be identical. So some of the things are the highly specialized subspecialty. For instance, one thing that we can't take care of here would be, for instance, something that involves eye trauma. So anybody who has a serious injury to their eyeball would have to go usually down to Mass General Eye and Ear. So those are some of the specifics that most level 1 trauma centers can accommodate. So how has this changed our designation? This graph shows in red are the transfers out. So if you're a trauma center, you hopefully you can't transfer everything out. You need to be able to accommodate. So you can see that our numbers were fairly high, and over time they have been going down, that we're sending fewer and fewer out. There are certain things that we do have to send out, and we'll go into that with another slide. But the other nice thing is the transfers in. This shows that over the years, and especially after our designation, is going up and up. So we're seeing more and more transfers. We had to get the word out, both at the state level and just local communities, as well as EMS. It's like, hey, we're a trauma center. You don't have to put your ambulance out of commission for 2 hours to take somebody to Dartmouth. You can bring them to us. So if that map I showed of New Hampshire, there's not really competition in terms of the level 2s. Portsmouth is the seacoast, and so they'll get a lot of stuff down the coastline that can now stop there instead of going straight down to Boston. Manchester, also far more populated down there, that they get stuff there, and the toll booths tend to be the boundary. Anything north of the toll booths will come to us, and south of that will go to the Manchester trauma centers. So we continue to look for increasing numbers of the trauma patients. Now, one of the smaller hospitals up north, they may have somebody who's very critically injured. What they're going to do is they're going to probably call several hospitals at once, and they want to hear, yes, we'll take your patient. because they just want that person out of their ER to get the appropriate care quickly as possible. This graph, nicely colored and done by Katie. I don't want to take any credit for putting this all together. This comes out of our trauma database, and basically it shows you here's what we have to transfer out. And it kind of makes sense if you notice the vast majority of what we send out are pediatric patients, because we can take care of a child with maybe a minor, fell off a trampoline and broke their wrist sort of deal. But if it's a child that's critically injured, they need to be in a pediatric trauma center. And that could be either Dartmouth or into Boston. And then burns. Not all trauma centers are burn centers. So somebody who has significant burns, and this just happened yesterday, we need to send them out to a burn center. We stabilize them, we see them in our ED, we have the full trauma response, but we cannot take care of that patient, so they need to go out. And the other specialties, some special neurospine, eye injuries, as I already mentioned. It's rare that we get a patient request because we're in the business of saving lives, so it's not a time to think that my insurance won't cover this, or I don't really want to go here because I live somewhere else. So those are not really immediate concerns. Ortho hand, sometimes they're highly specialized, especially around July 4th when people tend to blow their fingers off. Sometimes we have to send those out. Want to add anything, Katie?
Nope, I think you covered that.
This shows transfers in, and based on the map you saw, you can see that our top 3 transfers in come from the northern region because they're not equipped. They may have one ED doc, very small hospital, no ICU. They are going to probably be sending out anybody with significant injuries. So our top 3 players in terms of transfers in is Lakes, Spear, and Franklin. But we have received patients from all over. We've even received patients from hospitals that are geographically very close to Dartmouth, but Dartmouth may be full at the time and can't accommodate an ICU player. So this is all a collaborative effort statewide that we try to do the best for our patients. And myself and Katie participate in state trauma, not meetings, but committees, because we get together with the Dartmouth people, all of the other smaller hospitals. We meet at a regular basis, not in person anymore, but we're meeting to discuss and constantly improve the trauma care in the entire state.
Yeah, for the first time, we've actually started seeing patients from out of state. We had not seen that until this year, but Bridgeton, Maine, and Springfield, Vermont has started sending us patients because we are the closest center that had the capability to care for these patients. So it'll be interesting to watch that trend over the next few years as well to see if that continues to be something that happens.
And quite often we get out-of-staters just because, like the northern regions, there's a lot of people visiting the area. They may live in Massachusetts, New York, whatever, and they're up here skiing, the bike accidents on the mountain, various winter and summer sports where they live elsewhere, but they get injured here. One of the new changes is that we've now implemented a transfer center. It's a phone-in call transfer line. This is, I will say, a work in progress. We're still tweaking it. It is something that's implemented by a lot of the level 1 trauma centers. It's basically a one call. Somebody in an ED, small community hospital, has somebody who's critically injured, they're stabilizing them, they may be intubating them, and they need to send them to an appropriate trauma center. So it's a phone number where they can make one call, give their information, and get a yes, we will take that patient. This is the fastest thing. As I said, because of the bed crunch in most hospitals, most community hospitals, including ourselves, when we have to send a burnout, we may call a couple places just to find out who can say yes the quickest. So we're striving to improve that for our referring hospitals, in that having a number where you can get through to somebody quickly, we can hear the information and make the appropriate decision to say yes. In other words, we don't there may be some patients, it may be somebody who, you know, it's a 12-year-old with a spine injury or spine fracture. That's not something that should come here because we're not a pediatric center. So this is still a work in progress. In terms of our subspecialty list, we've asked our colleagues to come up with an always never list. In other words, what injuries, orthopedic injuries, will we always take? And for the vast majority, we'll take everything. Occasionally there, you know, a young child with serious orthopedic, a very young 4-year-old, they may say no, that is better off in a pediatric trauma center. A child with a brain injury, that should go to a pediatric trauma center. So for each subspecialty, we have a list of what we can always say yes to and what should not come here because it's not the best place for them. This is hopefully going to decrease the time in transfers. We're going to hopefully be able to say yes more often and more quickly so that the patients from the northern regions are coming to us and not having to go past us down further south into New Hampshire. It's going to minimize confusion from other emergency departments as well as confusion in our ED and all providers. And hopefully to streamline communication. Like I said, this is just not recently. How long has we been up and running?
About a year and a
So
half.
we're still tweaking it and working to constantly improve it so that we can improve the care of the trauma patients that need our services.
And I think it's also important to point out that we're trying to keep our patients in our communities, which I think is what patients and their families want. They don't want to have to travel 2-3 hours to visit their loved one, and it can be a significant burden on a family to have to travel to Boston in order to seek trauma care. So that's really what becoming a level 2 trauma center is about, is to keep the most amount of patients in our community. And even kind of Laconia is our community. It's you know, within our area, and traveling to Concord is significantly less of a burden on a family than traveling to Boston or traveling to Dartmouth, because it's not very easy to go east and west in our state. It's only easy to go north to south. So that's really what it is about. You can't get there from here for sure.
Dr. Patterson?
Yes.
Being the daughter of a Shriner, I was looking at interest on the list in terms of where you're sending. Do you ever send burns directly to Shriners hospitals?
Yes.
Or is that after the fact?
No,
we send
yes.
patients there.
Again, burn centers, there's actually a burn, I'm blanking on the name, but burn centers on a day-by-day basis know how many beds every burn center in the country has and how many are open. Because there's been some very prominent burn disasters where they've had mass casualties, you know, 20 seriously burned patients anywhere in the country is going to overwhelm a burn center because they're extraordinarily labor intensive, very long hospital course, etc. So they have not a registry, but they have a process that day by day they know how many beds are available in what hospital, so that if there is another big catastrophe like that, they know how they can disperse those patients across the country. It's not just local, because they can disperse them widely based on who's available. Another key thing that we do that people may not be aware of is injury prevention. We would love to be able to put ourselves out of business, but that's not going to happen. But we can certainly have an impact, because this is a forgotten aspect of the trauma program, and it's really not a well-publicized health health initiative. Sorry, she's here to spark my memory. Community education as to the impact of trauma, because most people think, oh, it's nothing to worry about, but a lot of what we see is preventable. There are certain true accidents, like, you know, a thunderstorm, a tree falls on your car sort of thing. There's no way to prevent that, except for maybe cutting down dead trees where that's could potentially be preventable. But a lot of this has to do with patients' decision making, deciding to drive 90 miles an hour around a corner, not so smart. So that's preventable in terms of education about those sort of things. Driving faster than the speed limit, especially with bad weather conditions, is an important thing. Drinking and driving, not wearing a seatbelt, being on a motorcycle and not wearing a helmet. There's a lot of things that we know can prevent injury that is a matter of education. It's underrepresented in the media coverage. You see a lot of publicity, fundraising for things such as, not to knock it or anything, not saying it's not important, but breast cancer gets a huge amount of, resources, funding, and all this. But if you look at the numbers of the healthcare impact from trauma compared to breast cancer, it's minuscule. The trauma impact is huge, but you just don't see it covered at all. And like I said, most people will go through their life saying it'll never happen to me, but it does. The other thing is there's a seatbelt legislation, and Katie and I just had a minor disagreement. She goes, everybody knows this, and I said, no, they don't. You may not be aware that of the 50 states, every state in the United States, except for New Hampshire, has a seatbelt law. And I've even had the most recent of our partners who joined said, of course we have a seatbelt law. It's like, no, we don't. It's been an ongoing legislative battle for well over 10 years. The trauma community, and I'm not just talking about locally here, but throughout the state, including people from Dartmouth, we all will come to Concord because of the capital here and plead with legislators. The most recent was only a couple months ago. There have been many laws that have gone forward that have been squashed. It's the live free or die state. So we've like to be able to say live free, don't die. No helmet law, yeah. Long history. If you have any interest in this, feel free to contact me otherwise, but we won't belay this, but that's one of our goals statewide, is to try to get not a primary but a secondary seatbelt law, because it just makes sense. The facts out there are that seatbelts save lives. Aging is, sure, another question.
I have a quick question on the seatbelt. Are the statistics such that New Hampshire has a higher rate of serious automobile accidents because we do not have a primary seatbelt law?
Our state is, population-wise, is much smaller than most other states. So if you look at national statistics, it's clear that seatbelts save lives. If you look at actual injury patterns, that's something we can get from our registry about who has seatbelts and who doesn't. Your chance of being thrown out of the car is significantly higher, and when that happens, your chance of death is tenfold. Wow. But it's not just the death. It's being thrown, out of your car, sustaining a spine fracture, so now you're paralyzed for the rest of your life, or you have a devastating brain injury that has a serious impact. So it's, a lot of times they'll focus on deaths. Live free or die is like, well, there's a big in between. That's not death. It's, serious injury where you're in the hospital for 2 months and rehab for 6 months and you can never work again. So that's a big impact. So did that answer your question?
Yes, thank you.
But we've tried that. We've tried using logic and all that, and there's still the mentality that, government is trying to take over, and we don't do that here in New Hampshire. So it's been a struggle. We have not given up the fight. We've still got stuff in front of the legislation, which we were just meeting about right before the pandemic hit. So that's kind of has put a squelch on that. For the time being, we do have a meeting upcoming. So all of us, and again, this is statewide, we are fighting the battle. But I think it is common, if they've done polls in New Hampshire where they poll people, especially people who have moved from other states into New Hampshire, who just assume we do have a law, and we don't. Going on, another injury prevention is myself, not Katie, but myself being a baby boomer, is that the population in this state as well as all across the country is going up because the baby boomers are getting older and older. And this has changed the trauma statistics more and more. The reason for people coming in and getting admitted with traumatic injury is from rather small mechanisms. In other words, just slipped and fell in the bathroom sort of deal. Instead, motor vehicles used to be the highest or the most common mechanism of injury, and now it's taken over by falls, and that's predominantly the old people falling. I'm not there yet, but so our hospital is seeing this as our #1 mechanism of injury, but like I said, it's not just us. This is pretty much nationwide, and it has led to community education. Again, there's some factors of this that are preventable. And our average age of patients is 61 years and older. And I'll let Katie expand a little bit more on our injury prevention efforts.
Yeah, so we have a lot lot of community programs. Our rehab department does a lot of education and safety and risk assessment for patients who have come in and fallen. One of the biggest predictors of a fall is that you've already had one fall. You are extremely more likely to fall again if you have sustained an injury and come to the hospital. Your statistics are quite elevated. So we have our rehab department, we have the Center for Health Promotion, who all offer programs on balance and strengthening and reducing your risk at home to prevent falls and being aware. Also things like checking for osteoporosis, your vitamin D levels to make sure your bones are as strong as possible. So if you do have a fall, you won't break anything when you fall the next time. So we have multiple different programs across the community in place, and we'd like to do some more community education on falls prevention because it's so important, because they are a burden and they are significant to our elderly population after they have a fall. After you break your hip, your chance of mortality within a year is extremely high. So it's something we'd like to do a lot more prevention and education to our community members before their fall occurs. Yeah.
Why is it when elderly take a fall, it always seems to be their hip that breaks, as opposed to an arm or a shoulder or a kneecap or whatever? Is there something about the way they fall, or is it something about the weakness in the hip?
I think
Can you repeat the question?
I'm sorry.
Repeat.
Oh, the question is, why does it seem that when elderly patients fall that they break their hip more than anything else? I think there are a fair amount of patients who do fall and break other bones, but they can go home from the emergency department if you break your wrist. When you get admitted with a hip fracture, you usually have to have that surgically repaired because you can't ambulate on a broken hip. So that's a significant, once you're in the hospital for a few days, you already are weaker, you need strengthening. So I do feel that there are a number of fractures that we see in our elderly, but I feel that hip fractures is one of the most significant because of the requirements for surgical repair, and then you are hospitalized, and it takes a toll on the body at that point in time.
And I'm sure Dr. Burns, our orthopedic surgeon, can probably explain, there's probably some physics reason why that particular part of the femur breaks more commonly. But she's right, it's very debilitating. You can't walk at all in it. They always have to have surgical intervention. The falls in elderly is actually extremely common, and I kind of found this out on a personal level. If you ask any of your elderly relatives if they've fallen, and this is hopefully a question that family practice asks patients, is how many times have you fallen at home? My own mother would fall quite a few times, and she wouldn't tell anybody. Why? Because she's afraid that, going to consider her unsafe, and she's going to be put away in the nursing home. So that's a big fear. Elderly people will kind of limit their activities and stuff for fear of falling, especially in New Hampshire when weather, ice and all that. Even if you're in the best, have great balance and all that, when the surfaces are slippery, falling is not that unusual. So it is a understated mechanism that may or may not lead to injury, but it's certainly much more common in the elderly who have osteoporosis. Their bones are not as strong, so will break. Ribs are much more common in the elderly just for the same reason. And then older people are on medications, and particularly blood thinners, where hitting your head and young and healthy may be no issue, but if you hit your head and you're elderly and you're on Coumadin, that could be lethal when you have a bleeding inside your brain. One of the other educational initiatives, we've actually given a presentation on this before, I forget, it was 1 or 2 years ago, is the Stop the Bleed initiative, and that there's a website on this. This is also a national initiative. It's now being pushed by the American College of Surgeons as well as other organizations, and it's basically to teach people without any medical background how to control hemorrhage that could potentially kill somebody, especially if you're talking about remote areas, hiking in the remote areas or something you can do that is going to potentially save a life. We work with philanthropy to match funds. Our goal is to put stop the bleed kits in every classroom, in every school that's in our catchment area. We're not the only ones in the state doing this. Elliott and Dartmouth are two other places that are trying to focus on their areas as well. We provide the training. This is kind of a train the trainer. You teach people like school teachers, whatever, to then go out to their community and teach more people. So hopefully it will exponentially spread. And we've actually had some feedback from people who have taken our course and then done things to save either somebody or even their own life. I've had patients who come in who put their own tourniquet, working in a workshop, cut their arm, and was able to put their own tourniquet on. The kits supply the actual supplies and the knowledge on how to do this safely. It is a collaborative effort, as we said, and we also work, anybody who wants us, we will come teach them. It's
Once
kind of been on
social distancing
exactly. It's kind of been on hold because of the pandemic, but hopefully we'll be able to resume. In terms of pre-hospital care, we've made some changes. We've now instituted an EMS timeout. So when the ambulance people bring in a trauma patient, you may see shows and all that where there's a lot of talking, a lot of noise and all that. We make everybody be quiet and let the ambulance people give their report, move the patient over, and no questions, no noise until they're done with their report. That's been a big culture change, but it's led to a lot more satisfaction from our EMS colleagues. We have a new EMS medical director and trauma liaison. Shout out to Dr. Rob Ricks. He's been wonderful for our trauma program. Any issues we have with ED, he's easily reachable, and it's been very good. He also is the author of the popular EMS Pro. You want to expand on that at all?
He does a newsletter and sends it out to our EMS pre-hospital EMTs and paramedics on some just education, and they are informative but also very humorous, and he does a great job with them, and they're very pertinent to what we see in a timely fashion. So, and then we also go out and we do community case reviews on traumas that they have sent to our hospital, so they kind of know what happens after they drop them off at our door and any learning experiences. They are fantastic collaborators in our Stop the Bleed. We could not do this program without them because they have really engaged in this program and teaching in our communities. We do NCCP education, which is the paramedic education. They need continuing education, and we do grand rounds once a year where trauma is the topic, and invite our EMS colleagues from all over the state. So.
In the emergency department, it's nothing like the TV shows, which you may be familiar with. We have trauma team response training, and this is, you can't get good at this unless, since we're not a high volume trauma center, the level 1 trauma centers tend to see it like every day, several times a day, so you tend to get good, but we work on, since we don't see a high volume, we have trauma team training where we get everybody involved and go through simulations just so that we can streamline things and make sure everybody has input and things run smoothly.